So, beginning to move towards a close, I'd like to ask you what the role of government is in all this and what they should be doing. Jim, you've got a national role as President of the Association of Directors of Public Health. What does government need to do in this area?
Make policy choices for prevention and not against prevention. So let's be honest, every government in the last 40 years from, Our Healthier Nation, which was 1994, right through to the Wellness Review in 2002, to Marmot's Review in 2010, we said you have to invest in prevention if you want a sustainable health service and a sustainable economy. And in fact, Derek Wanless, who was a banker, said if you don't do that, the NHS will be in massive crisis and unsustainable by 2022, and indeed here we are. So make a policy choice for prevention and stop chucking 1% of the budget into it. Secondly, health is not about the NHS. The NHS is not the biggest. Precious though it is, absolutely precious though it is, saved my life when I had cancer, but it's not the biggest producer of health, nor should it be expected to do things which are not in its job. Third thing is government, we love you, but you've never been very good at joining up, ever, throughout my entire life. Why don't you actually let us do the joining up and listen to local, rather than looking out and assuming it's one size fits all and you want 151 upper tier versions of this across England and 56 in Scotland and 22 in Wales. Other nations are available. But it's that kind of, you are not the experts. Actually, it's the people on the ground who know about innovation, and let us join up. And I think the fourth thing is we have to create a culture that compels us to work together from desire. And finally, stop all these silly little one-off bits of money that come out every 5 minutes and you have to do separate governance for, and chase, and you have to have it spent by this year. And it makes the voluntary sector's job almost impossible, but it actually makes the job of doing the job. We spend all our time filling in forms rather than delivering outcomes. So if you deliver those four things, which I think translates as be serious about policy, be serious about health inequalities, set the direction, tell us what you want, and then with the kindest way possible, get out of the way and let us get on with that, we'll do the job. Thank you.
Cheryl.
Well, I definitely agree on the prevention agenda. I think that's. But I think we can look at that across the pieces. Perhaps there's sort of standard way we would think about prevention. So in terms of HIV, stopping people getting HIV in the first place. But then thinking about how we can prevent people living with HIV having greater needs. So self-management. I mean, most people with HIV are self-managing very well. So how that can be supported and going forwards. And I think we all know, that there are going to be budget difficulties. So supporting people, building community capacity, those sorts of things that can be set, the tone for that can be set at a national level. I think there are also, we haven't really touched on stigma today, but stigma is a huge problem. And wouldn't it be nice if it was compulsory for all healthcare workers just to engage in some sort of HIV training, so that people living with HIV would know that they could go into their any healthcare service, and actually that the people they were dealing with wouldn't stigmatise them, and they would understand what HIV was and understand what that meant.
So that's still a significant issue, is it, for when people are in front of a clinician, that they still experience that?
Yeah, I mean, there's stigma across society. We know that there is stigma amongst healthcare workers. Obviously, not all healthcare workers. We wouldn't want to sort of make that accusation at all. But we know it's an issue, and we know there's a way of responding to it. In Manchester, they're now making HIV training important, I think it's compulsory across the board for all the healthcare workers in Manchester. And actually, I think it's a 20-minute program. It's not a massively intensive program. But so if Health Education England could just roll that out across the piece, wouldn't that be nice for all people living with HIV? I think there are other things we can think about. I've already sort of mentioned building community capacity, but I think that sort of fits in with some of the other agendas the government has. So those national level things that maybe we can tap into that already exist. So there are some things there. Another thing that we haven't really touched on today is around data, and I know UKHSA is actually doing a lot more work around, I mean, obviously they do a lot of data collection already, but they're moving into working out good indicators for quality of life and stigma and all those sorts of things. So those national level, again, perhaps not quite government, perhaps in the way you intended, but national level things that can.
So that's the National Health
support.
Security Agency, isn't it, which is bringing together a lot of this data.
Yes, of course. And then the other thing I would say, again, that we haven't quite touched on today is about monitoring standards, because obviously we have got the national level service spec, we have got the CRG, the clinical reference group, which is setting the standard. But with this devolution, I think people want to feel assured that there is going to be good level monitoring and that it's not going to suddenly become a sort of postcode lottery kind of model. I know that's a bit of a cliche, but you know, that sort of concern that people might have. And I think if there are national level, and I think NHS was working towards this anyway, but sort of a national level monitoring framework, which everyone understood, I think that would sort of alleviate some concerns around standards being different in different areas.
Ruth, see, Cheryl's touched on something very powerful there, hasn't she? This inherent tension between national and local. And you know, a lot of the debate around ICS is about where that tension how it should be resolved or where it should sit. So what do you need nationally to succeed locally from your point of view?
So I think from my point of view, Core 20+5 has been very helpful in terms of saying, actually, if you address the needs of that Core 20, the 20% most deprived, that is really what we need to do to tackle health inequalities. But I think we can go a bit further in that, in terms of saying locally, what are those most complex and vulnerable populations? What are their needs? And how do we target our resource to their needs? And I think HIV is one of those groups. So what do we think will make the biggest impact? Where should we be putting our money? I think prevention is obviously a no-brainer, but there's also lots of other things around.
Should be a no-brainer.
Yes,
certainly
yes,
if not. Yeah.
Yes, but I think that how do we come together as a system and do that? So how do we look at things like aftercare? How do we look at things like cost of living advice? Because I think that's something that's important for all kind of deprived or for complex, vulnerable populations. And for me, it does come back to measurement. So in the NHS, we have a lot of measures, and they're very important in terms of A&E times, cancer waiting times. But I was listening to somebody recently saying, well, actually, even if we hit the 80% screening target for cancer, if that 20% we miss are made up of the ethnicities and the populations that have the worst outcomes, it's a bit pointless. And there's something similar here, that what are the most important measures that say we're really successful as an ICS? And to me, it does come back to things like equity ratios and saying, actually, what is everything we've done? How is this combining to better outcomes for our most complex, vulnerable populations? And I think if we could crack that alongside everything else, then I think we could say that ICSs have really done a good job.
Great. Now, I'd like to invite each of you just to make any closing remarks you'd like to add, but also to just say, looking back over the work you've done with people living with HIV, what have you found most inspiring or powerful in that experience and the people you've met and the work you've done? Cheryl?
Well, I've before working for National AIDS Trust, I actually worked for a disability charity, and I don't think I've met a community of people who are so engaged in their work as the community of people living with HIV. That's not to suggest there's anything wrong with other people living with health conditions, but people living with HIV are very engaged. So I think that's something that actually can really get taken forward with this, that actually ICSs really can expect people living with HIV to stand up and be really engaged in co-production and be really interested in sort of moving this forward. We're getting a lot of calls. People want to know what's happening about ICSs. This is probably why we're doing this today, because people are really pushing to know what's going on. And I think that level of engagement is something that can be used, really exploited, and, well, not exploited, can really be used and taken forward and really work to enable really good co-production with ICSs.
Isn't it interesting that people are sufficiently tuned into these quite technical governance changes into the way that public service is being delivered, that people are on your phone saying what's happening with integrated care systems? That's a powerful message. Ruth?
So I think the most positive story I heard was from someone who works as a peer support worker locally. And it wasn't so much, he was talking about how rewarding he found the job, partly because it was what had made a difference to him in his own HIV care. And I think it really kind of struck a chord for me in terms of how this has to be about a continuous offer of care to a population. This isn't about one-off screening, although that's very important. The difference it made to one individual to feel listened to and to have the ability to now offer something back to that population. That's what I've found, yes, most heartening listening to.
Thank you. And Jim?
I guess probably three things. Sandro Galea, the American epidemiologist, talks about good health care and good public health as an exercise in love for your population. And I think, in my experience, the population of people living with HIV embody that, both in the love that they give to each other, in just how organised at self-managing they are, and then the love they give to a system which actually has failed them often. They still go on telling us what good looks like, despite the fact we still haven't got to where good looks like in a number of things. So those would be two things. And I think the third thing is a focus on doing what you're good at. So I remember when NHS England set up a Healthy Town Planning Unit thinking, but you haven't got any responsibilities under the Town Planning Act, why aren't you doing this with local government? And it just felt like a bunch of agencies reduplicating things. I still see in ICPs and ICSs people trying to reduplicate things we are not good at, from all sides of it. And if we take one thing from people with HIV, it should be we should focus on what we're good at and allow everybody else to focus on what they're good at and build the system. That way we'll get to better.
Jim McManus, Ruth Donaldson and Cheryl Gower, thank you very much.